Inspection begins as the patient enters the examining room. As he walks, evaluate the evenness and symmetry of his motion. The upper extremity, in normal gait, swings in tandem with the opposite lower extremity. As the patient disrobes to the waist, observe the rhythm of his shoulder movement. Normal motion has a smooth, natural bilateral quality. Abnormal motion appears unilaterally jerky or distorted to substitute an inefficient, painless movement for one that was once efficient but has since become painful. Initial inspection should of course include a topical. Now, turn your attention to the most prominent bone of the shoulder's anterior aspect, the clavicle. The clavicle is a strap bone that keeps the scapula on the posterior aspect of clearly etching the overlying skin, and a fracture or dislocation at either terminal is usually quite obvious. In the absence of the clavicle, the normal. Next, inspect the deltoid portion of the shoulder. The most prominent mass of the shoulder girdle's anterior aspect. The rounded loop of the shoulder is the result of the draping of the deltoid muscle. Normally, the shoulder mass is full and round, and the two sides are symmetrical. However, if the deltoid has atrophied, the underlying greater tuberosity of the humerus becomes more prominent, and the deltoid. Now, direct your attention to the posterior aspect of the shoulder girdle. The most prominent bony landmark is the scapula, a triangular bone that rests upon the thoracic cage. The outline of its ridges upon the skin makes the scapula easy to locate. In its resting position, it covers ribs 2 to 7. The posterior midline of the body, with its visible springs processes, lies midway between the scapula. Notice whether the spine is straight without lateral curvature or scoliosis. A spinal curvature may make one shoulder appear lower than the other, with the dominant side being more muscular. The Yergason test. This test determines whether or not the biceps tendon is stable in the bicipital groove. To conduct this test, instruct the patient to fully flex his elbow. Then grasp his flexed elbow in one hand while holding his wrist with your other hand. To test the stability of the biceps tendon, externally rotate the patient's arm as he resists and at the same time pull downward on his elbow. If the biceps tendon is unstable in the bicipital groove, it will pop out of the groove and the patient will experience pain. If the tendon is stable, it will remain secure and the patient will experience no discomfort. Drop arm test. This test detects whether or not there are any tears in the rotator cuff. First, instruct the patient to fully abduct his arm. Then ask him to slowly lower it to his side. If there are tears in the rotator cuff, especially in the supraspinatus muscle, the arm will drop to the side from a position of about 90 degrees abduction. The patient still will not be able to lower his arm smoothly and slowly, no matter how many times he tries. If he is able to hold his arm in abduction, a gentle tap on the forearm will cause the arm to fall to his side. Apprehension test for shoulder dislocation. To test for chronic shoulder dislocation, abduct and externally rotate the patient's arm to a position where it might easily dislocate. If his shoulder is ready to dislocate, the patient will have a noticeable look of apprehension or alarm on his face and will resist further motion. This test is similar to the patella apprehension test for dislocation of the patella.